Hello guys, welcome to Kitsunel Wits. Today I'll teach you how to take perfect gynecology history taking for your exam purposes. First of all, we'll take patient detail. In patient detail, we have to ask her name, age, gender won't be required as it's a gynecology. What is the importance of age is because during the childhood, diseases would be different like vaginitis or foreign body. During the adolescent age, polycystic ovary disease or menstrual disorder. During reproductive, fibroids would be common, pregnancy would be common, and in old age, generally carcinomas would be common and prolapse. Perimenopausal women will have prolapse due to birth injuries. Postmenopausal women will have prolapse due to tissue atrophy, and also disease would be different in perimenopausal women and postmenopausal women. What is the parity, how many live births she have, healing from. Education is important to know how much she can understand her illness. Occupation is important as if she's a laborer, then management of prolapse would be different. If she's a heavy load worker or laborer, then like during the management of prolapse, she have to undergo ward mayo with sarcospinal colpoplexy or macaduloplasty to prevent the wall prolapse. If she is working in factory or some industry related to asbestos, so she is prone for ovarian cancer. Socioeconomic status is important, like carcinoma of cervix would be prevalent in low socioeconomic status, endometrial carcinoma will be prevalent in high socioeconomic status. Marital status is always important. The importance of parity is if patient is nulliparous, then fibroids are very common and endometriosis is very common, and if she's multiparous then she will have adenomyosis. Fibroid and adenomyosis will have same presentation, except that adenomyosis will be tender and regular swelling in the abdomen, and fibroid would be non-tender and irregular swelling. And mostly to differentiate these both, best investigation of choice is MRI. Then you have to ask about chief complaint: vaginal discharge, bleeding per vaginum, mass per abdomen, pain in abdomen or pelvis, or mass descending per vaginum. Else you would be referred from some hospital. Generally with chief complaints only, like you will get to know certain diagnosis. If it is mass per vaginum, mostly it is prolapse. If it is mass per abdomen, mostly ovarian mass or fibroid. So in history of presenting illness, you have to always start by saying like patient was apparently normal this many months back or this many days back when she happened to notice the distension of her abdomen, and then you have to elaborate her symptoms, what was duration. In chronological order you have to present. You have to ask then certain symptoms, certain risk factors according to a particular disease. Like if patient says like she have history of discharge per vaginum, then you have to ask about what is the onset, what is the duration. Onset would be like sudden and postcoital, generally an infection or something. Then you have to ask about quantity, that's the type of discharge. Cervix have submucosal gland, so the discharge from the cervix would be like mucoid, and vagina have no submucosal gland, so the discharge would be watery from the vagina. Then you have to ask about whether is the color of the discharge, whether it is foul smelling in like cervical carcinoma or gardnerella, periodic discharge, or continuous or intermittent, whether it is blood stain or not, whether it's associated with pruritus or irritation. Pruritus only in vulva, not in vagina, could be part of like systemic disorder like diabetes, liver disease, or some chronic renal failure. Pruritus could be thereof because of skin diseases like psoriasis, scabies, tinea, leukoplakia also. Like leukocoria is a physiological excessive vaginal discharge which is periodical, so it would be non-purulent, non-offensive, non-irritant, non-pruritus. The other differential diagnosis, like whatever history you have taken from for vaginal discharge, it will help you to separate these certain and common diseases. Like cervical carcinoma will have abnormal bleed, like mostly postcoital bleed, which will be foul smelling. If it is trichomonas, then it would be frothy discharge. It'd be like pruritus would be present. Discharge would be of grey or green color. If it is candida, then it would be white, curdy white. If it is bacterial vaginosis, there would be no itching, no pruritus. So in postmenopausal women, these are the differential diagnoses like senile vaginitis and genital malignancies are very common, and prolapse with decubitus ulcer can also result into white discharge. If the patient says I have bleeding per vaginum, in that the most important part is to take menstrual history, like what is the rhythm of cycle, like whether it is oligohydramnia, polyhydramnia, or metrorrhagia. So all these terminologies you have to learn like especially in metropathica hemorrhagica, there will be like history of amenorrhea followed by prolonged bleeding. So these patterns can also help you in diagnosing the disease. Then you have to ask about how's the amount or the quantity of flow. Generally certain books or certain people will say like you can ask the history of number of pads, but what actually happens is like it depends on the hygiene level of the person. Like few women during her regular periods also they change 5 pads per day, but some women can change 10 pads per day also. But what you can say is like previously how many pads she was using, like approx 5, and now she has started using 10 because the amount is high. Generally if there is any clot, it means bleeding is high. Then therefore you can use the word like there is excessive amount of bleed because there is clotting. Generally menstrual would not have any clot because of fibrinolysin, whether it is with pain or not. Painless bleeding would be there in anovulatory DUB. Then it was the duration, what is the interval, continuous or intermittent would be there in polyps. Cervical carcinoma can have continuous bleed, postcoital bleed, intramenstrual bleed, any history of sexually transmitted disease, tuberculosis, OCP or IUCD, because these all can result into bleeding per vaginum. Age of the patient is among children or adolescent, then it could be trauma or sexual assault or bleeding disorders. If the age is reproductive age, then it could be like cervical erosion or polyp or cervical carcinoma, or postmenopausal cervical carcinoma or endometrium carcinoma. So the differential diagnosis of postmenopausal bleeding or spotting is mostly senile vaginitis, polyp, or prolapse with decubitus ulcer or cervical carcinoma. In uterus it could be endometrial tuberculosis, as TB is very common in India. Endometrial carcinoma from uterus, and if the patient say I have abdomen distension and I can feel some mass, or some doctor have told me there is some mass per abdomen, so like you can ask whether it is sudden or insidious, what is the duration, site, where it started, when you notice the mass, what was the size. Like approximately you can say small in size in the initially, and now it has grown within 1 month to this present size. Most of the examiner do not like when you compare the size, like it was a lemon ball size, now it is a football size. So do not try to compare. Best to say it was a small, very small in size, and now it has become to present size, because if there is rapid growth, it means that mostly the mass is malignant, whether it associated with pain or whether the mass is causing a pressure symptom. Like mostly in ovarian mass, the most common symptom would be dyspepsia, and which is most ignored symptoms. Patient will have abdomen distensions, weight loss, abdomen pain, dyspnea, nausea and vomiting. Most commonly what you will get in exam is mostly fibroid. Size would be approx 14 weeks of pregnant uterus, then only it will come above the abdomen. Other could be ovarian mass, adenomyosis. You can differentiate the mass whether it is benign or malignant through history. Like if the patient is a young woman and there is a longer duration of mass, like for years it has been there and it is not causing much symptoms, and there is no history of weight loss or cachexia, so it mostly would be benign. Like in malignant, old age would be there would be GI symptoms, there will be pain, like within months or weeks it have progressed to a increased in size. If the mass is there and there is abdomen pain also, if it is acute, then it could be torsion of ovarian cyst. If the pain is there for chronic reason, it could be fibroid uterus or ovarian cyst, mostly a cervical or endometrial carcinoma. Like in fibroid, generally they are painless. If there is pain occur in fibroid, then it could be because of red degeneration, which have a triad, like fever would be there, abdomen pain would be there, and there will be increase in the leukocytes. So these triad is there, and mostly for red degeneration they give just paracetamol for it. Could be torsion, infection, hemorrhage. Generally subserous and some mucous fibroid will go for the malignant change, and it is approx 0.5% chances. If the patient complains of pain in abdomen or in pelvic region, so you have to ask whether it is onset is sudden or insidious. Like sudden would be the rupture ectopic, or there is a hollow viscous perforation, like peptic ulcer which have perforated or something. If there is where is the site, like especially in appendicitis, the patient will say like initially the pain started around the umbilicus, now it has gone to right iliac fossa. Then you have to talk about the duration of the pain, what is the nature, like dragging type of pain would be there in prolapse, or if it is colicky type it would be because of spasm or some intestine obstruction. Severe pain could be there in ectopic or twisted ovarian cyst or acute salpingitis, whether the pain is intermittent or constant, or how it's related to her menstrual cycle, because menstrual pain could be there in fibroid. If it is mid-cyclic pain, then it could be because of ovulation. And aggravating and relieving factor, you have to ask. Mostly prolapse pain will relieve with rest, because after 6 to 8 hours uterosacral ligament will relax, so pain will relieve. Whether the patient is having vomiting or fever also, because vomiting fever could be there in UTI. Then the differential diagnosis of pelvic or abdomen pain would be, if it is acute in onset, it would be because of chocolate cyst or ectopic or acute PID or any obstructive mass. If the pain is chronic in nature, but if it is cyclic, then it could be intramenstrual pain or dysmenorrhea or premenstrual syndrome or endometriosis. Like if it is acyclic pain, then it could be uterine prolapse, PID, fibroid, ovarian cyst. If the patient gives history of mass descending paravaginum, you have to ask duration, how is the onset, like mass is whether continuously present or at the time of straining. It comes like straining, like in exercise, defecation or weightlifting, it aggravates the mass, or it relieves by lying down, whether it is reducible or irreducible, because the management will differ. If the mass is irreducible, mostly it will be because of local edema and venous congestion, so you have to first put glycerin dressing to reduce the mass, then you will take the patient for surgery and all. If there is inconvenience caused by the mass, like if the mass is there for longer duration, then what made patient to come now. And the most common differential diagnosis would be in old age, it would be prolapse, it could be a fibroid, or if the patient give history of hysterectomy, mostly because of walled prolapse. If you think it's prolapse, mostly mass descending per vaginum, then the patient will say like initially she had fullness of vagina, and now slowly the mass have come out of her introitus. I need to ask what is the onset, what is the duration, reducible or irreducible. Prolapse would be associated with low back pain because of stretching of uterosacral ligaments. That's why after rest of 6 to 7 hours, the pain will subside. They will cause urinary symptoms like cystocele, will have increased frequency, difficulty in initiation. Like some patient will even give you a history of like she's able to micturate only when she reduces the mass. You have to ask the history of UTI because urine stasis will occur. Stress incontinence can occur in prolapse. Stress incontinence means there is involuntary dribbling of urine, like whenever there is increased abdomen pressure in like cough or laughing. In this patient would not have prior urge to go for urination. The amount would be small, and it is basically due to increased intravesicular pressure than urethral pressure in the absence of detrusor activity. In history of prolapse, again you have to ask about anything which is causing increased abdominal pressure, like she have chronic constipation or chronic cough or lung pathology or ascites or abdominal tumor which is causing increased abdominal pressure. Because if these things are there, then you have to first treat all those pathology, then you have to go for prolapse surgery. Because if you do not correct constipation or cough, then even after the prolapse surgery it will result into walled prolapse. Patient may complain of constipation also in rectocele. Patient may even give you history like she have to push back her posterior vaginal wall to defecate. The other history of presenting illness which you have to ask is about pedal edema. Pedal edema could be there because of lymphatic obstruction and spread of malignancy, or deep vein thrombosis can occur. The history of diabetes and hypertension is very important, because if polycystic ovary disease, if there is obesity, diabetes and increased androgen, which you have to ask for any hirsutism or increased acne or change in voice from high pitch to low pitch. If there is a triad of hypertension, diabetes and obesity, then it be a corpus cancer syndrome. This polycystic ovary disease and corpus cancer syndrome both are the risk factor for causing endometrial carcinoma. Patient gives history of fever, basically it would be because of red degeneration of fibroid, any UTI or any abscess or endometrial TB. In UTI, you have to ask about burning, micturition, fever with chills, loin pain. Bowel and bladder history, generally we ask this in the personal history, but here we have to ask it before because in fibroid and all, it can cause pressure symptom, which will result into increased frequency of urine. You call it increased frequency when it is more than 8 voids per day, and there will be urine retention, especially if it is a cervical or posterior wall fibroid. If you are suspecting any malignancy, then you have to ask involvement of bowel or bladder, because it is very important for staging of the carcinomas. Like you have to ask about increased frequency and micturition, dysuria, hematuria, or any fistula formation or incontinence. If it is rectal involvement, then you have to ask about diarrhea, constipation, rectal pain, or bleeding per rectum. In menstrual history, you have to ask about early menarche. Generally, it be considered as less than 11 years of age, because early menarche is a risk factor for fibroid or endometrial carcinoma, because there is unopposed estrogen in the body. Then you have to ask at what age she attained menopause, if she have attained menopause, because late menopause is again a risk factor for endometrial carcinoma. In cycles, you have to ask whether cycles are regular or irregular, how many days of flow she have, what is the volume associated with clot. If clot is there, it means the bleeding is in excessive. Last menstrual period, this LMP is very important because it can help you to diagnose pregnancy or also amenorrhea. Generally, in menstrual history, you should know what is the normal menstrual cycle. Like, normal duration of menstrual cycle is approx 21 to 35. Averagely, we take as 28. Duration of blood flow is 2 to 8 days, and amount of bleeding is 15 to 80 ml. If the flow is scanty, then it could be because of stress or thyroid dysfunction. If there is high blood flow during the menstrual cycle, it could be because of DOBs or any carcinomas or any hormonal dysfunction. Mostly approx 50% of the fibroid would be asymptomatic, but approx 30% of them will have menorrhagia. Menorrhagia would be there because of increased vascularity, which will result into vascular ataxia, also because of increased surface area of the endometrium. Normal area of endometrium is approx 15 centimeters square, also because of reduced uterine contractility, and also tumor causes obstruction of endometrial venous plexus, which will result into stasis and congestion. Metorrhagia could be there because they are of submucous fibroid or some polyp. There could be tearing of vessels, or it could be associated with endometrial carcinoma also. Dysmenorrhea would be there because of some pelvic congestion or endometriosis. Fibroid may have infertility because of occlusion of fallopian tube, decreased motility and function of fallopian tube, and also fibroid will interfere with the implantation. It will cause thinning of endometrium and atrophy and ulceration of the mucosa. If hyperestrogenism is there, then it will result into anovulation cycle, and it could be associated with endometriosis or dyspareunia. In pelvic, endometriosis will have basically a triad of dysmenorrhea, infertility, and dyspareunia. Ovarian tumors generally do not cause any menstrual abnormality except granulosa tumor, because it will result into increased estrogen in the body. Symptoms of menopause are vaginal dryness, dyspareunia, hot flushes, and mood swings. In marital history, you have to ask about when she was married, how many children she have, when was the last childbirth, what is the contraception used. In this, OCP is very important, because OCP is said that it can reduce the risk of ovarian and endometrial carcinoma by 50%, and also most of the theories says like it can increase the growth of cervical carcinoma and fibroid also. IUCD is very important because IUCD can cause bleeding. If there is failure of IUCD, it can result into tubal or ectopic pregnancy. If the patient gives history of infertility and she have undergone some artificial reproductive technique, then there could be higher chances of ovarian carcinoma, because as drugs used for ovulation can result into minor ovarian trauma, which can result to ovarian carcinoma. Nulliparity is a risk factor for fibroid, endometrial, and ovarian carcinoma. Pregnancy is said to be protective against ovarian carcinoma, and multiparity is protective against fibroid. If there is history of recurrent abortion, then it could be because of submucous fibroid more than 4 cm, or to think of systemic lupus, because recurrent abortions can be there in SLE also. or any autoimmune diseases. Systemic lupus is a type of connective tissue disorder which can result into prolapse. Then you have to ask what was her age at the time of marriage, because early marriage and early pregnancy is a risk factor for cervical carcinoma. Then you have to ask about what was her age at the time of first child, second child, because if there is a very frequent childbirth and multiple childbirth, then it's a risk factor for prolapse of uterus or cervical carcinoma. History of breastfeeding, because it is said that breastfeeding is protective against ovarian carcinoma. Best thing is to tabulate the obstructive history under these columns. If you think it's basically prolapse, then you have to ask these certain history in the prolapse case, like history of any large fetus, what was the mode of delivery, because generally in vaginal delivery there is stretching, so they are more prone for prolapse. Any history of abortions, if the abortion was done by untrained person, or then it can result into prolapse. If the delivery was also conducted by untrained person or die, then it can also result into prolapse. Whether there was history of any fundal pressure or prolonged second stage of premature bearing down, because these all are the risk factors for prolapse. If there is multiparity with short interval, that can also result into prolapse. Like operative procedures, episiotomy is generally said to be protective against prolapse because it will prevent muscle stretching. And if there is a complete perineal tear, it is said that it is protective against prolapse because as levator ani will get strengthened. In past history, you have to ask about if she have already undergone some prolapse or fibroid surgery, then it could be reoccurrence. If she have already undergone hysterectomy and now presents with mass descending per vaginum, then it could be mostly a vault prolapse. Generally, hysterectomy, salpingectomy and tubal ligation is said to be protective against ovarian carcinoma, because there is a theory which says that cancer surge generally comes from fallopian tubes. Then you have to ask any history of tuberculosis, which is very common in India. You have to ask any history of pelvic inflammatory disease, which can present as tubo-ovarian mass or any ectopic pregnancy. History of any cardiac or diabetes or endocrine or thyroid disorder. Generally in hypothyroidism, you have to ask about cold intolerance, constipation, lethargy or galactorrhea. If there is any past history of breast carcinoma, if there is a BRCA gene mutation, then it can result to ovarian carcinoma. If there is HNPCC and currently she is having colon cancer, then it can result to endometrial, ovarian or breast carcinoma. HNPCC means hereditary non-polyposis colon cancer. In personal history, you have to ask whether she have any allergy to any medication, about her sleep. Mostly there would be loss of appetite and there will be severe amount of weight loss in malignancies and tuberculosis. If there is any history of addiction, especially alcohol and tobacco is considered to be risk factor for ovarian carcinoma. Smoking is a risk factor for cervical carcinoma, prolapse and atrophy. But it is said that smoking is protective against endometrial carcinoma and fibroid, as smoking decreases the estrogen state. If there is any history of high fat diet and obesity, it mostly is a risk factor for fibroid. Then any history of high risk behavior or multiple sex partners, because it is a risk factor for HIV and cervical carcinoma. History of dyspareunia means painful coitus because of endometriosis, adenomyosis, cervicitis, vaginitis. There are a lot of causes. History of drug intake is important because tamoxifen is a risk factor for fibroid and endometrial carcinoma. Fertility drugs or artificial reproductive technique can cause minor trauma to the ovary, which can result to ovarian carcinoma. There could be bleeding because of drugs, like if the patient is on warfarin, aspirin or anticonvulsant or estrogens. Progesterones are considered to be protective against fibroid and endometrial carcinoma. Family or personal history of HNPCC, which I said previously, hereditary non-polyposis colon cancer or Lynch syndrome. So therefore it is important to ask history of any family or personal history of colon, endometrial, ovarian or breast carcinoma. Any history of diabetes, hypertension or bleeding disorder. Generally there is a genetic predisposition of fibroid and bleeding disorders. Generally family history is not significant in patient with cervical carcinoma or prolapse. So finally you have to summarize your history. You can summarize your history by saying that 60-year-old post-menopausal woman, sterilized, with para 2, live 2, has come with chief complaint of mass descending per vaginum, with comorbidity of hypertension. If there is a mass, then you can say I am suspecting a benign lesion or a malignant lesion. or you can say, or you can tell the symptoms whatever patient is having, and then you can give your provisional or differential diagnosis, because history would not give a particular one diagnosis. So in differential diagnosis you have to give multiple diagnoses in it. Remember that you can miss out something in history after your clinical examination. When you are sure of your diagnosis, then also you can come back and modify your history. All the best guys, see you guys in my next video. Bye bye.